I'm a pretty casual person. You should feel free to interrupt me anytime. And I don't really have a whole prepared speech. So questions would actually be very helpful. But I'll just give you a little bit of background. So I'm a family physician. I've been in this community for 20 years. And before this, I had 5 years in the Navajo Reservation in Shiprock. I trained at the University of Washington. And like so many family physicians, when I started here, I built up a panel. I inherited some people, patients who had been with my partners who had subsequently retired. I saw women who were pregnant and helped them deliver babies. And as the practice got older and my own children got older, about 8 years ago, I stopped doing obstetrical care. And not surprisingly, as my career has gone on, my patients have gotten older. That's kind of the goal, right? And so I find as I go along that I spend more and more time with older and older people, and so I spend more and more time thinking about end of life. It's if you had asked me 30 years ago if I would have this much fun taking care of really older people, I would not have known what to say, but actually it's incredibly fun taking care of really older people. And so I'm really enjoying this phase of my career. So there were some questions on the talk that said, what can you expect from your doctor? How can you begin the conversations, and so on? I just want to preface my answers to those questions by saying a couple of very important things. Number one, it's always important to remember that although it really doesn't often look like this, you are in charge of your care, okay? And I know that the way the system is constructed, it does not support that reality. It sort of disguises that, but that really is the case. You are in charge of your care, and presuming you have designated a power of attorney to speak for you when you are not able to speak for yourself, that person is just as in charge as you ever were. So, and nothing really ever should be done to you, for you, or about you without your consent and knowledge. And I realize that the standard of informed consent in medicine is often really quite lacking, but I don't know that I can fix that for you, but I think the only people who can really fix that are the patients. You know, the medical establishment has had that ball for years, decades, for the entire history of medicine, and we've clearly failed at that. So I think it's really up to the patients to demand a better level of informed consent and autonomy, and it's not going to come from us. I promise you that. So I think, you know, forums like this are great. So let's see. So the other thing to remember that's very important, and I don't say this as a form of an excuse, but it's important to remember that when you're talking about a physician, you're talking about a human being who is absolutely fallible, right? I think every physician in their career is going to fail every one of their patients at least once. It may be a big failure, it may be a small failure, but it's just going to happen. And that doesn't mean it's going to be an irretrievable failure, but we should all just acknowledge that that's a reality, because if we don't acknowledge that, then we can't really prepare for it or manage it, right? And sometimes it happens, you know, in little ways. Like I told someone I would call them, you know, this afternoon, and I forgot to call them. And it's not a big deal, I'll call them on Monday. Sometimes it's terrible, you know, sometimes it's just awful, and everybody has to live with that for the rest of their life. So just remember that we are fallible, so don't put more trust in us than we deserve. And also, the other way to look at that is we need your help, right? So for us to do a good job, you need to tell us when we've failed you. Otherwise, that feedback loop is broken and we just go on our merry way. And actually, I think that happens a lot. I think patients are often reluctant to let us know how we've let them down. And that doesn't make us any smarter. So, yeah.
Are you under a lot of pressure as physicians, the insurance companies and the institution itself, to only see patients for so long and to move the patients on through? Because I know my daughter has some medical issues, and she has a lot of questions when she goes that she wants to share with her physician. and she, in one case, was asked not to come back to find a new physician. And is there a problem with, repeat the question.
Okay, so the question, are we under pressure to limit the amount of time we spend with a given patient? And well, that's a very deep rabbit hole. I would say the answer to that question is yes, undoubtedly. And where that pressure comes from, how it operates, how it results, I think is really variable. So I don't mean to dodge the question, but it's very complex. And yes, we are under pressure. I know of some institutions where there actually is a number of minutes you're allowed. For many other institutions, it's more subtle than that. But yes, there is pressure, and there's no way around it. Let's see. The other thing I wanted to say is I don't think of this as a one-time conversation, right? So, you know, it's a challenging subject. People's thoughts change over time. You know, we heard that it's important to revisit the conversation multiple times over the course of your life. I had a patient 2 weeks ago tell me, he said, you know, you are relentless. You just never give up, which is actually kind of true. But it was probably the 5th or 6th time I'd asked him about his advance directive. And you know, we were getting closer. He had moved it from the filing cabinet to the kitchen table, from the kitchen table to the counter. He'd actually filled it out, but he hadn't gotten it notarized yet. And you know, this is probably a couple of years of work, but I'm okay with that. It just, you know, people need to think about these things thoroughly. And you know, a thoughtlessly filled out advance directive is actually not a good thing. So bad information is probably worse than no information. So I think it's an iterative process. You just do it over and over again till you're satisfied with it. So those are my thoughts. In terms of what can you expect from your doctor, it's as variable as doctors. So some doctors are going to be all over this. Some doctors, you'll mention this to them and they will just be like a deer in the headlights. And you won't get anywhere with them. So, you know, we're just humans and our training is highly variable. I can tell you that in medical school, I had this much training about the end of life, okay? Now that was admittedly 30 years ago, but still. And to my knowledge, people were dying back then. So I would say, how do you begin the conversation with your healthcare provider? Any way you want. You know, I think, you know, it's hard to start these conversations, so I would just blurt it out in whatever moment seems right, or just whenever it comes out of your head, that's fine. Yeah.
We've been encouraged several times in this discussion with a medical doctor, but in my experience, both with my dad in the hospital and my mom in her care unit and hospital visits, their general physician was never consulted on their care in the hospital, or at least to my knowledge, they never were. So how do we create that linkage if we're actually going to have a conversation with our GP to get that information to the hospital?
Okay, so the question is, how do you make sure that the information, if you have had the conversation with your primary care physician, how do you make sure the information gets where it needs to be to the hospital or to the care unit? I would like to say that that happens seamlessly, but I know that it doesn't. In my office, what's supposed to happen is when we have the conversation, when we get to a stage where we actually have a document, we put that in your chart. We forward that to the hospital. In our town, we only have one hospital. So the hospital has a registry. They're supposed to put those into their registry, and they're accessible to anybody in the community with access to the hospital record, which is most everybody. I don't know how reliable that system is. I've definitely seen it fail. So I would say any decent medical care facility that does primary care should have someone available 24/7 on call and should be able to access that and forward it as needed.
Yeah, I understand the document might be available.
Yeah.
But I'm talking about the conversation you would have with your general practitioner, if that conversation would get to influence the medical provider.
Okay. So the subtleties of the conversation and the relationship you have with your primary care physician, how does that get translated into care? That, unfortunately, being as humans aren't divisible, is going to depend on the availability of your primary care physician. So, and I think you're probably leading towards what's happening with fragmentation of care, where you have a separate hospital system, separate from your primary care physician. And you probably all know that this is going on. So when I came to town 20 years ago, and for the ensuing probably 12 or 14 years, we were all rounded on our own patients in the hospital. And every morning you'd see this huge sort of slew of physicians go to the hospital. They'd all see 2 or 3 patients, and then we'd all go to our offices. That rarely happens anymore. So now there are hospital teams who are there 24/7, who are rounding on the patients in the hospital. This piece of the relationship is often a casualty of that system, I would have to say. When I have...
It encourages us to be as clear as we can.
Absolutely, right. So be as clear as you can, have the directives, you make sure they're filed both places, and advocate for yourself or your loved ones to say, we've had this conversation with our primary care physician who's known us for 2, 4, 10 years, and we would like their input. And it's not that difficult for the hospital team to call someone like me and say, what's the story with this person? What do you think we should be doing? This is what the family's telling us. If I have a patient in the hospital and we get to this stage of conversation, I'll often go there to have that conversation. Not everyone has the time to do that. There was a question back.
So for 6 years I worked at the Valley Hospital, and it was very common that as we had some pretty critical cases, the rounding hospitalist would call the PCP and say, what kind of this is what the paperwork says, but now we have this family and everyone's wanting something different. And they would have those conversations with, what did we say in your office? And PCPs would come back, and that would help harm, and shed some light when we were doing big family meetings in critical care. I often, would call as a social worker the PCP's office and say, no one has the durable power of attorney paperwork. Do you have it on file? And you guys would fax it over to us, or whatnot. So there's some pieces that
Right. People are busy and they just don't bother to call, but I think the phone call is can be really, really helpful. The other thing is, it's not just about the directive or the decisions that you made. One of the things that happens when people are really ill is they kind of become depersonalized. They're in the hospital, and if they're not that responsive and the people there have never met them, it's hard for the folks interacting with you then to really appreciate you as the human being that you are. And, it just makes a difference if you're a known, real person with a history and a life and a story. So beyond just the details of what's written on your directive or the conversation you had about this, it's helpful to know that this is a person who did these amazing things in their life, who has this story with their spouse, who traveled to Ecuador when they were 72, and whatever those little tidbits of humanity are. Those are actually very, very important. And when you talk to nurses in the hospital and respiratory therapists and people who are taking care of people, if you can just have a tidbit of humanity and history attached to you, I think you get better care. So that's another thing that your primary care physician can provide.
Were you here for the last couple hours, or did you?
Just for the last talk before this one.
Okay,
Yeah.
So right prior to that one, I talked about voluntary stop drinking. That's how my husband died, so he didn't have to live into the late stages of Alzheimer's. And we've talked a lot about that today. In order for somebody to have a good death through voluntary stopping eating and drinking, they need good medical support. And what that meant in our case is that the doctor came to the house 3 times during the 9 days, and also was on 24-hour call, and there were times we called during the middle of the night. Would you be willing to engage in a conversation with me and maybe an elder care attorney so that we can develop a stronger support system for proper care for people who choose to do that in the future?
Sure. It takes a certain amount of infrastructure to pull this off.
It
right?
does.
And most practices are not set up with that kind of infrastructure. I can tell you that mine is not at present.
Right.
So when I've had patients in that situation before, it's, if I'm around, that's fine. But if I'm not in town, it becomes more difficult because what I'm willing to do and what I'm willing to ask my partners to do without a conversation and an established infrastructure, those may be different. And there's really no point in committing physicians who aren't ready to do this work because then it's not going to go well, right? So yeah, but absolutely, if someone is making those decisions to be at home no matter what, you really, really want to have a plan and an infrastructure so that you are not left hung out without the backup that you need, because sometimes that's okay, but it can be terrible if you don't have a good plan.
Right.
So,
Thank you.
yeah.
On the topic of the hospital, getting some more personal information about the patient from the physician, do you find that hospitalists are willing to call the primary care physician? Will you repeat the question?
The questions are, do I find that hospitals are willing to call the primary care physician? So to learn more about the patient. I would say,
On the family's urging.
right. That's just as variable as the physician. So some of them are, some of them are not. Different hospital systems operate under different pressures. And so this is where advocacy matters, right? So if you're the loved one and your patient is your family member is in the hospital, you can humanize that person by telling those stories. And you can basically demand that their primary care physician be called.
You can demand it.
Sure.
We tried.
Yeah, and I would say if you demand something like that you feel is essential for your loved one's care, and you don't get that request delivered on, then that's a reason to raise a concern. With whoever, yeah. The physician themselves, the hospital, whoever runs that service, And I say that full well, knowing that a lot of the hospitalists you're talking about, and I work in the hospital myself, some of those people are running as fast as humanly possible for shifts that run 14, 16, 18 hours. So I'm not making any excuses for a failure to perform, but those are the realities that some of the hospitalists are working with. But it won't change unless you demand it.
Is it basically the same with specialists, whether it's an oncologist, cardiologist, urologist, as far as communication with a primary care physician? As far as someone needs to advocate and say, I want you to talk to my primary.
To my cardiologist.
Say to the cardiologist, I want you to talk to, because they just know the heart, they don't maybe know the whole backstory.
Right. I would say that that's also just as variable as your specialists are. There are some cardiologists I talk to really regularly. There's some I almost never talk to. Right before I came here, I was talking about end-of-life issues with the gastroenterologist who I talk with quite regularly. There are others in his same office I speak to rarely. Remember, this is not like manufacturing automobiles. There is no standard, and so it's a very, very human endeavor. And it would be, I think, nice and reassuring to believe that you could count on getting, consistency, but truly you can't. Advocacy is essential.
I know when you go to the doctor, you usually are going for a certain kind of appointment. And like for a physical, they don't really want you to bring in other things going on because they're just focused on the physical.
Yes.
So if you were to talk about some end-of-life issues or advanced directive, is that something better to make an appointment just for that? Or is that something you could add in your stand for some other thing?
So the question is, what kind of an appointment do you ask for if you want to have this conversation? I'm scratching my head because I don't have an answer for you. So I'll just tell you how it works in my office, right? So I would say in my office, if you call up and you're coming in for a well exam, that an end-of-life discussion would be considered a reasonable part of a well exam because it's a healthcare maintenance activity. For me, if you come in with a broken ankle and you're not so uncomfortable that you can't have a reasonable conversation, it's not too distracting, we could talk about end of life. If you came in with a hangnail, we could talk about end of life. Because in the big scheme of things, how important is the hangnail versus the end of life discussion? On the other hand, that's just me, right? There are other physicians in my own office who would not feel the same way. And there are other physicians in other practices who are constrained in ways that I am not. So I guess I would just take the direct approach. I would call up the office and I would say, I want to talk to my doctor about an end-of-life plan, period. And then just let them deal with it, because there's no way you can sort all that out, right? We can hardly sort it out ourselves.
So one of the things you may not know is that as of January 1, 2016, the end-of-life discussion with your physician is now a reimbursable conversation. It was not a reimbursable conversation prior to that. One time, but at least that one time.
And actually, I was just to tag on to that, many of your physicians don't know that. And it will be a while to realize that. And once they realize it's reimbursable, they won't know what to bill for it. I only found out how to bill for it last week. So, yeah, so just be aware that they'll be surprised.
A year ago, my wife and I in a life discussion with our primary doctor, and each of us, even though we were together, had a separate appointment. So it was two appointment things at one time, but it needed to have that amount of time to discuss it. And I think to go in and say, well, we're going to do this in 5 minutes is not going to work. You need to use as much time as necessary.
I couldn't agree more. And actually, I did an appointment, a back-to-back appointment just like that on Monday. And it worked well because, well, in this case, it worked well because they had talked to each other before, so there were no big surprises. And their ideas were enough in line with each other that it was a fairly parallel conversation. But yeah, I guess I would say our schedules are our problems, and you just need to ask for what you need and what you want, and just let us do the best we can, because until you demand it, it's not going to happen, right?
So we're nearing the end of the time. Sure that there's time for a couple of general questions. If you want to pursue this, that's fine, but if you also have a general question. So Mary, I can see you in the back. What's your question?
I want to know if you're accepting new patients.
Mary wants to know if Dr. Wu is accepting new patients.
So it's interesting. I stopped accepting new patients in about 2006, and I've actually added a nurse practitioner to help me manage my panel, because what I found is that as my practice gets older, the same number of people actually require more and more help. So this is a whole other conversation, but so the short answer is no, I'm not.
Are there any general questions that you have? Mickey?
Some of us here are aware of the success of La Crosse, Wisconsin with the percentage of advanced directives. And my goal is to do that here in Whatcom County. And so my question to you is, I've heard from many physicians that some of them are uncomfortable starting the conversation, and also even with the $86 reimbursement, they don't have that. So do you think that if there was an ongoing scheduled event, maybe at the head, where nurses talk to patients that were not told to go by the doctors, but directed there for the nurses to start the conversation, present information on what would be entailed in choosing what one might want for advanced directives, that doctors would direct the patients there?
So Mickey's question is if there were a place, central place where perhaps seminars could be held around some of these choices at end of life, would physicians refer to those conversations as the beginning of an advanced care directive plan?
I think yes. I would also say, though, it's very hard to change physician behavior. We're very kind of it's a relatively rigid profession. We learn rather slowly, and it's a little bit ossified. So changing behavior is difficult. I actually, for the people in this room, you should just understand that the physicians are not going to get this done for you. Okay, you are going to have to do this to us for patients to get what they need. And so my statement as a physician is I would really encourage you to be empowered to bring this to the medical profession, because it probably isn't going to happen otherwise. Our focus tends to be elsewhere. But I agree with you, Mickey, that having other resources outside the physician office is essential. I really was not able to get much traction with this until we started having WAHA doing this work.
Yes.
I just wanted to, for one thing, I'm with WAHA most of the time, and then Dev Cafe some of the time. We encourage people when they're filling out their advance directive, and this highlighted it, to find someone to be your healthcare advocate that's a Rottweiler. And make sure you choose the right person, the one who's going to get the job done. And you just, you said that, basically.
Yeah, we survived getting bitten, it's all right. We don't like to be bitten unnecessarily, but a few nips are okay.
Any other questions or comments? Yes, Margaret.
I brought up advanced directives with my physician, who's a little younger than me, and he doesn't even have it.
Oh, most physicians do not.
Margaret says that her admitted that he did not have an advanced
So I
directive.
think that's another place too that the internal, I'm not gonna fix it for you, but I was kind of shocked that, some of the physicians I talked to said that.
Yeah, most of them do not. Yeah, I know oncologists who don't. Yeah. Yes.
They have degrees in denial.
I work in the medical field, and I've heard lots of doctors tell patients you're too young for an advanced directive, right? And many doctors I've heard say that to patients who are 65 years old.
I'm all for advanced directives at 18. Get your driver's license, file your first advanced directive.
That's what I'm telling my patients. For the young, healthy people, it's never urgent until it's too late. So I think, everyone needs one. But doctors don't know any really that much more about this than you do.
Yeah, right.
If at all.
Yeah, so I want to remind you that Ying said he had zero training on end of life. The medical training is training to keep you alive. And we've gotten better and better at the technical fixes that can keep you alive long after you want to be alive. So this is why we're trying to foster these conversations so you can be empowered to make the choices that you want for yourself and your loved ones at the end of life. It's very, very important.
I guess I'll close with this, but I'm happy to for questions if you want. But just so you don't think I don't know anything about the end of life. It's true that I had no formal training in end of life care. So where did I learn what I know about it? I learned it from patients. Patients have always been my greatest teachers, and I learned this from my patients, which is a great gift.
Thank you.
Thank you.